Hello everyone. So today's topic for discussion is colorectal carcinoma. Colorectal cancer comprises 98% of all malignant tumors of the large intestine. It is the commonest form of visceral cancer, accounting for deaths from cancer in US next only to lung cancer. Peak incidence is in 60 to 79 years of age. In early age, it is associated with ulcerative colitis or polyposis syndrome. The etiological factors implemented in colorectal carcinomas are geographic variations. Colorectal cancers are more common in North America, Northern Europe than South America, Africa, and Asia. Second factor is dietary factor. Low intake of vegetable fiber diet will have low stool bulk and higher risk of colorectal cancer. Consumption of large amount of fatty food will lead to excessive cholesterol and their metabolites, which is carcinogen. Third factor is adenoma carcinoma sequence, in which normal colon is converted into adenomas. This adenomas will further change into carcinomas due to molecular defects, which we'll study later on. Fourth etiologic factor is hereditary non-polyposis colorectal cancer syndrome. It is an autosomal dominant disorder, familial syndrome characterized by increased risk of colorectal carcinoma and extraintestinal cancer, particularly endometrial carcinoma. HNPCC is due to germline mutations in one of the genes responsible for repair of DNA mismatch. Most commonly MLH1, MSH2, MSH6 and PMS2, resulting in microsatellite instability. In HNPCC, there is 50% risk of developing colorectal carcinoma for a first-degree relative of an affected patient in the direct genetic lineage. Patients with HNPCC are also at an increased risk for the development of malignant tumors at other sites such as liver, uterine corpus, urinary bladder, and several other organs. Pre-existing diseases like inflammatory bowel disease and diverticular disease for long duration are also etiological factors in colorectal carcinomas. In inflammatory bowel disease, ulcerative colitis is most common disease involved in colorectal carcinoma. This table is showing the molecular genetic pathways of colorectal carcinogenesis. So two pathways are involved: adenocarcinoma sequence and microsatellite instability. Adenocarcinoma sequence is involved in colorectal carcinoma in cases of familial adenomatous polyposis. And histopathology of carcinomas are adenomatous polyps, moderately differentiated adenocarcinomas, polyps leading to carcinomas. Genetics involved in this case is germline APC inactivation. Second pathway is microsatellite instability, which is seen in hereditary non-polyposis colorectal cancer. Histopathology. Now coming to the staging system of colorectal carcinomas. There are different staging systems: Duke's staging system, Hassler-Kohler staging system, which is a modification of Duke's staging system, and TNM staging system described by American Joint Committee. Now the Duke's classification as modified by the Hassler-Kohler. Stage A, Stage B, C and D. In Stage A, tumor is confined to the mucosa. So T1, N0, M0. No lymph node, no metastasis. Stage B1, B is divided into B1 and B2. B1 is when tumor is extending into the submucosa and no lymph node is present. No lymph node is positive. B2, when tumor extends into muscularis propria, serosa may be involved or may not be involved, and no lymph node is positive. C1, when tumor involves the muscularis propria and lymph node is positive. There is metastatic carcinomatous deposit in lymph node. C2, when tumor extends into serosa and lymph node is positive. Stage D is when distant metastasis is present. Spread of tumor. Colorectal carcinomas can be locally invasive, involving the surrounding tissues. They may go to liver, lung, and bones by hematogenous spread, or lymphatic spread involve mesenteric lymph nodes going to para-aortic lymph node to cisternic gyli and may involve supraclavicular lymph nodes. There can be transcoelomic spread, which may involve the peritoneum and then to the ovaries, forming Krukenberg tumors. So, diagnosis of colorectal carcinoma can be made by digital examination, sigmoidoscopy, colposcopy, radiology, and barium enema. Tumor markers like carcinoembryonic antigen is demonstrated in some cases. This is seen in 40.5% cases without metastasis and 70.5% cases with metastasis. Thank you.